Thank you,
And
Rick.
thanks for joining us, Amy Priest, and mute. Okay, thank you.
Yeah, no pressure, thanks. So my name is Sarah Dugan. I'm a mental health pharmacist. I'm faculty at Neomed. And our didactic presentation was actually on the schedule for March. Was on the schedule for March prior to the whole COVID meltdown. So we got bumped just a little bit. But this had come up from some of the discussions and questions that had arisen in prior ECHO sessions. So our topic for today is pharmacogenomics and medication, focusing treatment or muddying the waters. So what I'm going to attempt to do in our didactic blitz is to define some common terms for pharmacogenomics so that we're all speaking the same language, list the information that can be communicated through that genetic testing, and then look at some places where we could actually use the genetic testing in clinical practice. So I wanted to start at the very beginning. So what is pharmacogenomics? What does this even mean? Oh, where's the other one? There we go. There are actually two terms that you may hear, and I think it's important to clarify the distinction between them. Pharmacogenetics and pharmacogenomics. Pharmacogenetics is a study where they look at all of your genetic material to look for differences in drug response, but they're focused on one gene, just one. Pharmacogenomics is the topic of my talk for today, and that's a search for genetic variations that lead to differences in drug response that looks at your whole genome. So we really are looking at all of the genes and seeing, are there differences in there that could potentially predict how a person would respond to medication? And because I want to make sure we're all on the same page, so genome is all of our genetic material. So absolutely everything that makes you who you are. In the genome, at least for the humans, we have 23 different pairs, 46 chromosomes total. And those are all these little different colored squiggles that are on the screen. On each chromosome, there are a whole bunch of genes. And within this genetic material, that's specifically where we're looking. We're gonna look for differences that are in the codes here. So that genetic material is made up of nucleotides. So all of these little letters that line up. And those letters are essentially like letters of the alphabet. So in our DNA, all those letters are instructions. And the body then uses that DNA to create RNA, which is like a messenger that translates it and then uses that information to make things. So it'll make proteins, it can make enzymes, it can make receptors, it makes all of the chemical neurotransmitters that transmit signals in the brain. So it really is the master instruction sheet. So if we're looking at any differences in there, it could potentially have some really big changes in the way that a person responds. So those specific things that we're looking at that we are going to talk about today are single nucleotide polymorphisms. I'm going to refer to them as SNPs. So a SNP is a change in one base pair. So those little letters that were up there, a change in just one of them. Now that change may not result in any difference whatsoever. It takes 3 of those letters to create one amino acid, which is a building block of all of our proteins. So sometimes if it's one change, it still creates the same amino acid. We get the same protein, the same receptor, nothing's different. But if it's in a different location, potentially it could change the entire system. If it makes a repeat, if it says that it's turning off this entire gene, it can have a major change in the way that a person responds by just having one letter different. So the SNPs are the main thing we're going to be looking at, but I think it's also important, there are a lot of genome-wide association studies which look at not just one SNP, but any changes that we see in patients. So maybe it's not this one change that made a difference, but it's these 3 changes here that then created something a little bit different that we were looking for. And unfortunately, that's not the whole story. We thought if we knew what the code was, we could undo the code, we could crack the puzzle, and we would know exactly if you have this set of instructions, this drug would be best for you. That's not the way it works. There's a ton of information on epigenetics. This is a whole new area of exploration. And it's actually mechanisms that turn genes on and off. So you might have the right code, but for some reason that gene may be turned on or turned off and it isn't working. It happens naturally. So all of your cells have the same code, but you have hair cells and eye cells and liver cells and nerve cells. And it's this epigenetics that turned on different pieces to make them all those different cells. That was supposed to happen. We also find that the environment can impact how much those genes are being turned on and turned off. And we're getting more and more information about this. So all of that information, maybe your metabolism says, you know what, I can use all of the calories that I eat really effectively and I'm not going to be gaining weight. And that's the genes that are all turned on. If we start doing things, maybe we're not as physically active, maybe we don't have a good sleep schedule, maybe we're under a lot of stress, those genes start to turn off a little bit. So some of them are turned off and all of a sudden, maybe I'm eating the exact same amount, but the weight starts to come on because those environmental stressors actually turned off some of those protective genes. So there's lots of different additional things that impact the way that our genes are expressed. The good news, there are protective factors. So all of the good lifestyle things, balanced diet, getting an adequate amount of sleep, meditation, and physical activity can really help promote having the genes that we need turned on working efficiently and effectively. So that's all the background information. What the questions come up is about pharmacogenomic reporting. So when the patient gets their cheek swab sent in, they get a report. The report usually looks like this, somewhat like a stoplight, red, yellow, and green, which can be a little bit misleading. So the green tends to be a category where it says you can use these medications just fine. There's no issue with your genetic profile. The yellow is use with caution. So we need to be a little careful with these. Doesn't mean we can't use them, but we do want to be mindful. The red means we have to monitor the patient a little bit more closely and maybe think about using a different medication, something in one of the other lists. But the red does not mean these are not options. It just means we need to be a little bit more careful if we're using them. And unfortunately, I think the way that it's set up, a lot of times people see things in the red category and they're like, these aren't options for me, I can't use that. So that really requires a lot of education. So what could these results actually tell us? Well, our goal is that you take a swab and we can figure out, hey, these would be the best medications for you. So this is, I really like this little infographic. The goal would be that you're in the white group on the bottom right. So the drug isn't toxic, you don't get side effects from it, and it works for you. We really don't want you to be in the red group where you're getting side effects and there was no benefit from the medicine whatsoever. But it's not that easy to be able to pull this all apart. We're able to get some information, but we haven't quite gotten to this level yet. That's our ideal. That'll eventually, hopefully we want to be there, but that's not where we are today. So what the information can tell us falls into two buckets. One is pharmacokinetic, how your body processes the medication. The other bucket is how the medication actually works in your body, the effects that it has, both what we want it to do as well as the side effects. So we're going to focus first on the pharmacokinetic information. So there are 4 things that are related to pharmacokinetics, what your body does to the drug. It needs to absorb it. So if you take a pill, how does the drug get into your body? Where does it go? So if we're taking something for anxiety, we want it to be up in the brain. How does your body break down the medication metabolism, which we're going to focus on, and then how does it get rid of it? We have some of the best data related to that metabolism. So your liver is the biggest drug cleaning factory that we have. It has a lot of enzymes, proteins that are in there that help break down the medications. I included a handful here, or not even a handful, just 3 of them here that tend to be pretty common that we see. The 2D6 is the one that we're going to focus on. So this enzyme in particular happens to be on chromosome 22, and it has more than 120 different variations. So there are so many different combinations. And this is one of the main drivers for getting genetic testing, is we actually see huge variability in how active this enzyme is. So they break people into 4 different categories: ultra-rapid metabolizers, extensive metabolizers, intermediate metabolizers, and poor metabolizers. I think I have the details on the next slide. So what that means for people is that those that are poor metabolizers may actually have almost no active copies of the enzyme, or their enzyme doesn't work very well. So any medication that uses this enzyme to get rid of it, they're going to have much higher concentration because their body doesn't have the protein to break it down to get rid of it. So that's going to have dosing implications. On the flip side, there's also a handful of people who are ultra-rapid metabolizers. They have a lot of copies of the enzyme. So instead of having 1 or 2, they may have 10 or 15, which means if they're given a medication that uses 2D6, they can chew through that medication really quickly, and they might need much higher doses. And we actually have some labeling information for currently available medications specifically related to this. This is not all of them, it was just an example that I wanted to show you. For something like Abilify, it's metabolized by a couple different enzymes, but if it is a poor metabolizer of 2D6, so if you get that profile back, then we want to be a little bit more cautious, and they recommend using half of the dose. So we're not going to be, we may not be pushing to the upper end of the dosing range because they would have many more side effects because their body just can't process it. So that could be useful information. Could we adjust medication anyways? Yes, these would be patients when they start taking Abilify, they might get side effects pretty quickly. So we would know that we would need to use lower doses. So it's not a must to get the testing done, but it could be helpful in preventing some side effects for these patients. On the other side, so the effect side, the pharmacodynamic side, what does the drug do to the body? There are 2 different categories. So side effects, can we prevent bad side effects? We have a couple examples of medications. So carbamazepine, Tegretol, and oxcarbazepine or Trileptal. So these can be used as mood stabilizers. And this is one example where we want to do testing before we start the medication. The reason for that, in patients who are of Asian descent, they may have this one SNP, so one genetic variation, where they're more sensitive to developing a pretty significant side effect, something called Stevens-Johnson syndrome. So it can be a very serious disorder of the skin and mucous membranes, and most patients require hospitalization. They would have to stop the medication, it would no longer be an option for them. So we screen these patients to see if they have that. If they do, then these are not options for them. Or if we are going to use it, they have to be monitored incredibly carefully. There are very few places that are doing that in the world right now. So this would be one example where that would be information, genetic information that we wanted before we started medication. That's one of the few. Other side effects of interest that people are looking for information on genetically are things like weight gain. So our antipsychotics, things like Zyprexa and Risperdal and Seroquel, they can cause weight gain in patients. So there's a lot of interest in knowing who will gain weight if they're started on these medications. So this was one study that looked at, it was a meta-analysis. So it looked at 72 different studies that tried to genetically evaluate patients that were on antipsychotics. They were able to narrow it down. So they found 9 different genes and 13 of those different SNPs, so 13 of the different combinations that were associated with weight changes or changes in BMI. So these particular, the genes that had the biggest effect size, I listed here. So the adrenoceptor, so this works on norepinephrine. dopamine, which is one of the main actions of our antipsychotics, the D2 receptor, serotonin, and then the melanocortin receptor. So each of these have been associated with roles in appetite, in the adrenoceptor actually innervates some of your fat tissue. So they have roles in how much you eat, how quickly you eat, if your satiety, when you feel full. So if there are changes in these, those patients might be more sensitive to having changes in their weight when they're given an antipsychotic that works on those pathways. The results that they found only found that there was not even a moderate, really kind of a mild to moderate signal. So yes, these were definitely present, but they couldn't say that it was a predictor. Hey, if you have this change in particular, you're definitely going to gain weight. It was the folks that gained weight had these particular changes in their genetic profile. So we're not quite at the point where we can predict that. If we see these changes, we may know that those patients are more likely to gain weight, but it doesn't mean that everybody does. So it's not quite the information that we wanted to say, hey, we know you need to stay away from this because you'll gain X amount of weight. We're not there yet, but they're doing lots more trials to look at that. And my slides won't advance. So on the side effect side, we can't really predict that, but can we predict efficacy, that this is going to do definitely what we want it to do? The answer is unfortunately no, not quite yet. So I picked two trials that looked specifically, one looked at kids with autism spectrum disorder. So they were being treated with risperidone for over a year for aggression, overactivity, and repetitive behaviors. So they looked at a bunch of different markers. And what they found was that there was one, the dopamine 2 receptor, which is one of the places that risperidone works it's one of its main actions. And they did see that patients who had a particular sequence for that receptor were more likely to have a stable clinical outcome. They were more likely to be a responder and to not have as many of those behaviors that they were being treated with the risperidone for. So 40% of them were considered stable. But 13% of the patients had that same sequence, even though they weren't really responding. They were considered not stable by the authors. Interestingly, that was the overall impression. When they looked at each of the behaviors individually, the difference was almost the same, but statistically it didn't come out as any different. So they really weren't able to see a difference between those two groups there. So we're still looking to see if there's a particular sequence that would predict these patients would respond best to this medication, at least for autism spectrum disorder. Same thing for patients with ADHD. This also was a meta-analysis, so they used data from 36 different trials, and they found a whole bunch of genes that were correlated to methylphenidate response. So that's your Ritalin, or Ritalin type products. These particular agents are responsible for the reuptake of norepinephrine. Actions, interestingly, actions where the receptor where guanfacine and clonidine work, as well as the enzyme that may break down the norepinephrine and the dopamine that the methylphenidate works on. Again, it really wasn't a surprise that these were areas, they were high interest areas we were looking at, but just because the patients responded well, it wasn't necessarily a predictor of the methylphenidate efficacy. It could just be, hey, if you have this particular sequence, this receptor is not going to work as well with the norepinephrine, so you'll have more norepinephrine out there to actually take care of all of the ADHD symptoms. So it may be more of a signal of if you have that sequence, it's more likely to be more effective than, hey, this is the signal where this would be the best medication for our patients. So again, not quite enough data to be able to predict response. So in thinking about that, the genomic testing can give you information. It's definitely another piece of the puzzle. And maybe we can get some additional information about side effects and dosing. So there might be side effects we can avoid, like with the carbamazepine, or knowing that we need to be a little more conservative or a little more aggressive if they have fewer or more copies of enzymes to break down the medications. But we're not at the point where it actually gives you targeted information to tell you this is exactly what you need to use for treatment of these conditions. Lots of trials still going on, but we're not quite there yet. Turn it back over.